Welcome, everyone. Thank you for joining us for this policy webinar this morning regarding health economics in laboratory medicine, key concepts and opportunities. So for the next 75 minutes, we're going to be going over some key concepts in laboratory medicine and its relation to health economics and some key emerging issues. And hopefully you'll be able to, you could check out, there is a question and answer function. So if you have questions as you go along, please insert them in the question and answer function, not in the chat, but if you do put them in the chat, we will end up finding and trying to address them. So I'm here with my colleagues who I'll introduce in just a moment, but Don, if you could just advance to the next slide. Just wanted to provide, our home offices at the Institute of Health Economics are in Canada, in Alberta, and traditionally we provide a land acknowledgement for the Indigenous lands that we sit on, and thanking them for allowing us to conduct the meeting. We recognize that meeting participants are located in many different places, and just wanted to note that we respect the treaties that were made on those territories, and there is the land acknowledgement outlined there, and certainly encourage people to take attention to the lands that they do sit on and honor the original inhabitants who lived on those lands as we engage. And we do try and incorporate Indigenous perspectives and develop respectful relationships in all the work that we do at the Institute of Health Economics. Next slide. The IHE, Institute of Health Economics, we're an independent not-for-profit organization with key competencies in health economics, health technology assessment, and knowledge transfer. And we have a number of activities which are listed here. We serve as the home for the network of Alberta Health Economists. We're a member in the host agency for the International Network of Agencies for Health Technology Assessment. So we're part of the club that does thumbs up or thumbs down or modified thumbs up or thumbs down for technologies and how they're incorporated into the healthcare system. Next slide. The presenters are Don Husereau, who's a senior research associate with the IHE, who will be providing a bulk of the presentation, myself, who's senior policy director of the Institute of Health Economics, and our colleague and friend Craig Ivany, who is expert in laboratory medicine, and he's the chief provincial diagnostics officer for the province of British Columbia, and a long experience. And Craig is going to be providing some ongoing comments and reflections from that perspective throughout the presentation. Next slide. Just a disclosure, support for this presentation. We are very grateful to have support from Abbott Laboratories in supporting the activities. And I will be having some slide information at the end. The IHE has been a long time inaugural partner with the Abbott sponsored Univance program, which celebrates excellence in laboratory medicine internationally, and how it can be used to improve healthcare. And I'll providing a bit of information on that at the end. And as disclosure, both Craig and I sit and participate in the advisory committee to that international program. Next slide. So outline of the topics covered as we're going to go through, it's going to be in 5 sections. One is health economics, a brief overview of the key concepts and the rationale, economics of laboratory medicine, some specific characteristics in laboratory medicine and its and the value that it brings to healthcare, and some issues around measurement of that value. Some policy issues that need to be addressed. With the support of Abbott, we did a bit of a consultation around key policy and emerging issues in laboratory medicine that we're going to provide an overview of that work, which might lead to some future webinars and activities that we're going to do. Some final statements about how economics can be your friend rather than and using it to shape a better image and a more practical application of laboratory medicine. And then Craig is going to be providing some comments throughout, but allow him to have a reflection at the end from the perspective of laboratory executive who uses health economics and practically and how you might as a lab executive incorporate that into your decision making. But I'll pass over to Dawn to provide begin the discussion presenting around health economics.
Thanks, John. A daunting task presenting about health economics from the Institute of Health Economics, but I'm very pleased to do so. The assumption here is that for some people, this is actually a newer concept. I think people are aware of the idea of economics and economic evaluation, but we want to make sure that everyone has a sort of mutual understanding. So why, in the first place, do we even think about health economics? It's because every dollar we spend in the healthcare system has to be spent somewhere, and it can't be spent in two places. So if we invest in laboratory services and we have a fixed budget in the healthcare system, that means that we may not be able to invest in other places. And if we think about where we invest in the healthcare system today, well, a majority of the money that we spend is on hospitals and the infrastructure to support that. And then drugs and physicians tend to sort of incur similar costs to healthcare systems in provinces in Canada, and are on the rise as particularly health human resources, hospitals and physicians require people to support services, and they need living wages. And so the increases also don't necessarily go away. So we see all continued increased expenditure. We in Canada, we do spend a lot of money per capita among the OECD countries on healthcare, and it's usually expressed as a percentage of GDP. So, okay, why do the healthcare budgets have to be fixed? Why not just print more money or raise more money? I guess we can't print more money. We'd create inflation, but we could raise money. We could raise taxes. If we do that, we incur opportunity costs elsewhere. We have people now who, with any tax increase, suddenly go from just a bare minimum standard of living to something that's not sustainable. We could say, okay, healthcare requires more money. So in the province of Ontario, we allocated roughly 50% of the provincial budget to healthcare. Why not just take more from education, from the justice system, social services, and other large-scale programs? Well, could. However, we're reducing opportunities in those sectors as well. So we can't escape this notion of opportunity cost. If we spend something within the healthcare system, we either have to take resources from elsewhere in the healthcare system or elsewhere in our socially financed system of government. It's just not something we can get around. So we do care about money. We have in healthcare always competing alternatives. Particularly, there's always new technologies, and we do see innovations in laboratory medicine. We see other innovations, other technologies, including new procedures of care, new drugs, and we have to think about how much should we allocate to fund these things versus other things. And so health economics, and particularly economic evaluation, which is part of the larger field of health economics, is attempting to help with this decision making. It's tempting to focus on decisions of should we pay for this or should we pay for that? Or should we pay for this compared with other things, or what we're paying for now? What's an optimal allocation of resources is essentially what it's trying to get at. And ultimately, the demand for healthcare services are greater than what society can afford. I have one life, and I'm not really willing to give it up for anything. And when somebody is requiring rescue or their life is in jeopardy, as a society, we tend to want to rescue that person, and we may spend tremendous amounts of money just to make sure they're going to be okay. And that's multiplied by all society. So we ultimately always end up in a situation where we can always spend more. And so we have to make rational decisions based on what we're getting for what we're giving. And that's ultimately what economics and economic value is what are you willing to give up to get something? So you have to think about the trade-offs of what you're going to get and what you're going to give up. And of course, if we give up, that means we can't allocate those resources somewhere else. So the idea of economic evaluation and health economics and healthcare is really ultimately, so that we can get the most and for the amount of money that we have to spend. And if we think about other costs in the healthcare system, so again, remember, you can't spend twice. And once you commit resources to one patient or a care pathway or a program or a service, you can't necessarily commit it to other things. And we can think within the healthcare system as having all of these types of costs, of which diagnostic tests are certainly, and laboratory services in general are one component of that. We can also think of other healthcare related costs that might fall on other people, including non-health costs. So, patients have to find transport and they have to find parking, and or they may have to pay caregivers and that kind of thing. And we have these indirect costs as well. We have to think about the costs to society. Sorry, sorry, I have lost my ability to go backward, which is unfortunate. There we go. There we go. So we have to think about how other larger costs to society. If we can get somebody back to work with the new technology, that actually could increase productivity. And if a person's actually able to get back to work, they're able to be more productive. So they're less of a cost and they're more of a contributor to society. They can actually pay taxes, which ultimately fund healthcare if they're able to work. So another way to look at this is we have these inputs. This is what we're willing to give up. Is the healthcare budget to get these things. These are our inputs, services, programs. But of course, these things in and of themselves have no intrinsic value. The healthcare administrator, the healthcare system is not thinking it would be great to pay physicians just because they're physicians. What we're thinking is, what can these services, what can these specialized personnel, specialized technologies, what can they do in terms of what do we get when we give up healthcare money? So we're giving up to get these goods and services, but what we're getting ostensibly are things that we want, and they could be, and as a society, we have to decide what that is. And typically we think of, lives saved as an important thing. We also think of the alleviation of human suffering, but there are many dimensions of, if we think about in any particular patient, things that we might think are valuable. And I already mentioned things like productivity. Sometimes we just giving people hope is actually may have some value. We may have other priorities. We might think that getting benefits in cancer is important, or in pediatric care, that the same outcomes in children versus adults are probably more highly valued. So we do, as a society, have to think about what we want to get. And we also have to think about what we want to give up to get those things. And we also have to think about who gets the rewards, and where does the spend occur. And this is the constant problem of having a health system that is operating effectively and efficiently. So when this is a strict definition of economic evaluation, as I said, within the realm of health economics, we use economic evaluation to really help us with these allocation decisions and these allocation problems. And an economic evaluation is just an analysis, like a business case. And we define it as a comparative analysis of alternative courses of action in terms of costs and consequences. So we're not just thinking about, hey, if we spend this amount of money, we're going to be able to detect this many cancers. What we're thinking about is, hey, if we spend this amount of money, we're going to detect this many cancers, versus if we spend the money elsewhere. It could be, there could be a new test, and we're asking the question, do we spend money on the new test, or do we just continue to spend money on the old test? But it's always comparative, because we're always interested in what we're getting versus what we're getting now, or what we're getting versus other things. So if a person just does simply a cost analysis and says, getting this new test, you're going to lay out $500 million, that's not an economic evaluation. It doesn't tell you what we're getting relative to other things, and it also doesn't tell you what it costs relative to other things. Or similarly, if we just do an analysis and say we're going to get these amount of cancers detected if we pay this much, again, it doesn't have that. It doesn't tell us about the comparative benefits and costs versus other things. And so this is an important aspect of economic valuation. So hopefully that's understandable. We're not talking about expenditure. We're talking about value. We're talking about what you're prepared to give up to get something. Now, how does that apply to lab medicine?
Yeah.
Well,
and Don, just because I did mention, we'll just stop at each section. And Craig, I don't know if from explaining economics internally or externally to within lab medicine, whether you had any kind of, we'll stop at each section. If you had any kind of reflections or comments about the challenge, certainly I know the lab, often the benefits received from lab are not found in the lab itself. They're found in supporting other people. But just wanted to allow a chance for you to have a couple of comments before we move to the next section of lab particularly.
Yeah, sure. Very quickly, the perspective of building in economic evaluation in terms of looking at lab medicine is vital, and how it fits within the health system. But some of the things that I think we need to think about really is smart health strategy should encompass investment in lab services accordingly. So in and of itself, it's a challenge to place it against other elements of the health system. But when you think about the objectives of the outcome and working backwards, building a health strategy and looking at all of the elemental pieces, I think that's where the economic evaluation of that service delivery versus and the desired outcomes versus service delivery of desired outcomes of other, I guess, services that a health system could deploy. If you think about it in terms of that fulsome requirement and build and recognize and build in the investment in lab services through that lens, I think is a valuable perspective, and just one perspective on that broader context.
Okay, no, thanks, Craig and Don. So just over in the next section, looking at lab in particular, I think.
Yeah, so I mean, we've talked sort of generally about economics and health economic evaluation. Now, how does that apply to lab medicine? What sort of trade-offs are we making specifically in lab medicine? And it has been said that lab services, said by others, including the editor of the Lancet, that lab services is often thought of as the Cinderella of modern medicine. That is, it's an integral part of healthcare. However, it's often not well understood how important it is in serving the healthcare system. It seems it just doesn't have, often laboratory service providers are providing to other physicians or other parts of the healthcare system, and not necessarily at the face. Of course, we have community-based labs, but that's only part of laboratory services within a healthcare system. And just how important it is, and how much of a vital and critical role it plays is often overlooked or underestimated. It's also very complex. People can't just sort of build a lab and just go. The idea is that a laboratory, because it's serving other parts of the healthcare system, it has to be integrated within the healthcare system. And then within laboratory services itself, what you find is it's highly specialized. And so you do have highly specialized service providers who, if the healthcare system is large enough, may not even sort of know what the other's doing, because you have everything from people who do clinical biochemistry, which are the standard tests that a lot of people are aware of, like cholesterol tests and tests for blood sugar, but all the way to highly specialized things like medical microbiology or pathology, and then even molecular diagnostics and the like. And this is just a snapshot of all the different types of specialties. As we already mentioned, poorly understood by the healthcare system, and often just seen as a cost center, rather than something that's actually driving value, driving efficiency. And so in this paper from the Lancet, they mentioned that pathologists are involved in more than 70% of all diagnoses in the UK National Health Service. So every step of the way, laboratory services is playing an important role.
Don, if you might, just hovering on this for a second, that lab is typically about 3 to 4% of the total system spend when you look at a healthcare system. But what's remarkable is people outside of lab want to keep it as a 3-letter word, lab. But this slide illustrates that there's actually can be up to 8 or 9 different medical disciplines in lab medicine. And I would argue that clinical chemistry is as different to transfusion medicine as obstetrics is to orthopedics. And yet it's bundled as this thing called lab. And it is very much simplified down to a cost center mentality in most jurisdictions. And that's what lab has to work hard to reimagine right across the system. This is true anywhere you go.
Yeah, I can imagine this would be as complicated as saying, well, we're paying for doctors just in general, and then they have to sort out amongst themselves what that looks like. That would be a difficult thing to do. So that's one aspect of thinking about the economics of lab, that it's high, there are different specialties. Another aspect is that, I guess similar to other technologies, but more nuanced, laboratory tests themselves are not always perfect. Just because you have a positive test doesn't mean you have disease, and just because you have a negative test doesn't mean you're free of disease. And that applies for just about every test. So we do have to think about, when we think about the economics, we have to think about some larger issues about the performance of the test, and we'll talk about that in a bit. And because it's a critical contributor to clinical decision making, we also have to think about how it integrates with decision making. If a laboratory test arrives later than a physician needs it to make a decision, it's of no value and of no use to anyone. And so there are elements of timing and how it integrates into a process of care that have to be really strongly considered. Ultimately, we have to be convinced that introducing new laboratory tests or new services is actually going to lead to the things we want, which is more health. You know, I have a scale at home that I use to weigh myself. It's highly accurate. It doesn't help me lose weight necessarily. I have to do other things. It's the same with laboratory services. It's one part of a larger part of care to help us achieve the goals that we want to get to. So we also know that laboratory systems are becoming increasingly aware of the impact of diagnostics, particularly with an advent of new and innovative technologies like genetic testing, which are more costly, but can have bigger payoffs and can actually return investment to the healthcare system, which among healthcare technologies is a very rare occurrence. You don't see that with new technologies typically, but you do see that with laboratory medicine sometimes returning their own investment back to the healthcare system, although not to the lab itself, but to other parts of the healthcare system, like keeping people out of hospitals, etc. And so that it also becomes difficult when we even think about the value and we think ultimately we've made people more productive, or we're keeping people out of emergency departments, or we're having some other benefit. Those benefits may ultimately not affect lab budgets. And so again, then that makes it critical that we are thinking about value more holistically and across all the cost centers in a healthcare system, even especially when we have a healthcare system where we have a lot of siloed budgeting. And the way we look at this is a diagram from, I think, again, the Horton paper, talking about, again, this ecosystem of how we have to think about laboratory medicine and other types of testing. Because remember that diagnostic medical imaging plays a similar type of role in helping aid diagnosis, as do the physicians, and their knowledge of disease play a role. But we do think that economic evaluation can help along the entire continuum, from understanding the magnitude of a problem in terms of its costs, all the way to thinking about the optimal care pathway, or how things should be communicated, diagnosed, reported, what the ultimate treatment should be, and outcomes. Economic evaluation can help with all of this because it's not just focused on that technology, it's focused on processes of care and all of the outcomes that might be associated with technology, including the use of other treatments or the use of other human resources or health resources and the like. So it can really play a fundamental role in helping us think about what does best care look like. We also have to be mindful, in addition to having all these hyper specialties of laboratory medicine, when we're thinking about the economics, that testing can be used for lots of different purposes. Testing can be used to diagnose a disease, confirm that a person actually has a disease. It could also be used in a screening program to try to catch people who may have disease who are otherwise healthy. It could be used to actually help us or help a physician or others understand how likely I am to have an outcome, which is the prognosis part. So I already know I have the disease, but how bad is it? Testing is used also for prediction and monitoring disease. To help us understand whether we're responding to treatment and the like. And frankly, testing also has enormous implications for research. With testing, we have better understandings of disease. We have better understandings of the state of population health. And as such, testing can be used not only to help with decisions about care, because it helps understand diagnosis, prognosis, and the like. It can also help healthcare systems understand the state of health of a population, by understanding the distribution of disease and the extent of it, etc. So not only are there many different types of testing specialties, there's also a lot of different uses. And this complicates things, I guess, in a sense, since when we do an economic evaluation of a cancer drug, we're typically talking about length of life and suffering and what the impact is on a person. It's even though there are different cancers, it's a little more straightforward, whereas with laboratory medicine, there are many, many different contexts and many, many different outcomes that we might want to achieve. Laboratory medicine is also, and I alluded to this a little bit before, highly dependent on implementation. As I said, a test can be of no value at all if, for example, the results are delivered too late. So how do we make sure the results are delivered on time? Well, we have to think about the implementation of the test. We have to think about when a test is performed, how long it takes to actually achieve the results of the test, and how the population itself plays into this. We may have a test that is really good at detecting a rare disease, but it's going to be of less value in a population that is less likely to have that rare disease. It'll be of much more value in a population that's more likely to have that rare disease. And so we can do other things. For example, the value of that test, it might be more valuable, for example, to use a test in a person who you already suspect has disease versus not suspecting that they have disease. A pregnancy test is not worth much when it's used for me, but in a young woman who is showing signs of pregnancy, it might be very valuable. I alluded to this before. Because of all of these different contexts and all of these different applications, testing has a wide spectrum of value. And I did mention that there are many tests that can actually return investment, i.e. create savings to the healthcare system. But there are also tests that create a lot of spend. And testing could require huge amounts of investment if could be a cheap test for lots of people. This is an example of school-based screening for Tay-Sachs. So this is like screening every child in school. So even if the test is fairly cheap, it could be expensive. In this case, it was $670 million Australian, but it turns out it will actually return all of that money. So it's a cost neutral value proposition. Whereas, testing a person for familial hypercholesterolemia, probably with some suspicion that there is familial hypercholesterolemia in the family, actually leads to much faster diagnosis, better care, and returns money to the system by avoiding all of the complications of, or reducing the complications associated with this disease. So it's a crapshoot. We can never ever say that all tests are valuable. We can never ever say all tests are expensive. It just depends on the context. And that actually is why more than ever we need economic evaluation as well, because economic evaluation is used to look at the what we're getting for what we're giving up in one or various contexts that are well defined. So we need to do that kind of work to understand how well it can deliver within our own healthcare system. I did mention this before as well. One nuance is that just because you have a positive test doesn't mean you actually have the disease. And this itself varies from test to test. Some tests are very good at telling you have disease if you have disease. And we call that being sensitive, or they're highly predictive of disease. Some tests are very good at when they're negative, they're negative. And we've all experienced this through the COVID era, where we have everything that seems like COVID and we do the test and it's negative. Well, maybe that's the test. Maybe that's how you administer the test, which is the implementation piece. It could be a number of other things, but this has real implications. And when I teach about health economics and health technology assessment, which is where economic evaluation is applied to make policy decisions. I give this example of, a drug for a very fatal disease, small cell lung cancer. There's no new drugs. A new drug comes along and actually could provide a person with an extra year of life. And this is for a disease where you're only expected to live 5 years. Now you have, so this is great. You're getting an extra year of life. Now you have a new drug that comes along, but it requires a test to see if you have a mutation, because it only works in people who respond positively to the mutation. And the test is 90% accurate. And I ask people participating, if 1% of people have this mutation, and the test is 90% accurate, that is, provide a positive result, 90% of people who have the mutation, what's the chance of a patient with a positive test will benefit from the drug? Well, it seems like a no-brainer that a lot of people are going to benefit, but the actual answer is less than 10%. And this is because of the failings of the test, that we have a large amount of people, 1,000 people. Well, if you have, there's only going to be 9 of them that actually have the mutation, and the test will detect 9 out of 10 of those. But if you don't have the mutation, the test will still may still report that you're positive, just because of the sensitivity and because of the performance of the test. So 9 out of 108 tests will actually benefit after 9 out of 108 positives will benefit after a positive test. And that's actually less than 1%, never mind less than 10%. The takeaway that I try to give people is that testing and understanding and interpreting testing is not a straightforward exercise. It's difficult. And so those that are actually making decisions around testing need to be mindful of these technical nuances with testing. When we extend this to the realm of cost effectiveness now, we could say, well, that drug will give you 1 extra year. We often in health economics use this term QALY, which is a quality adjusted life year, 1 extra healthy year of life. So I ask again, with dollars in mind, if a test costs $1,000 per patient and a drug costs $5,000 a month, and we think that $50,000 for an additional healthy year of life is effective, what you believe is the value in terms of the additional dollars for the additional healthy years of life. And I'm not going to go through this now as a busy slide, and we can do the calculations, but I'm going to show them to you. But again, it's not an exceptional value. The figure that you come out with when you do the math is $1 million for healthy years of life. And so if the healthcare system doesn't want to spend more than $50,000 for a healthier life, that means that they would have to spend $1 million, which means that they could be like 200 people that would have benefited from this amount of money being spent elsewhere in the healthcare system, where $50,000 could buy you a healthier life. It means it tells us that there's an opportunity cost, because we've exceeded a threshold by which there is opportunity cost, which is this $50,000. This is a simple example, relatively, but again tells you how we live in a world where we hear about the promise of testing and personalized and precision medicine, but it's not always valuable. It depends on the context. It depends on the test. It depends on how well the test performs. And these things have to be thought through. And that's why, again, economic evaluation can be very helpful. There are all other challenges with economic evaluation besides these technical parameters. I'm not going to go through all of them. Again, it's highly dependent on the clinical pathway. There might be missing data. We may have challenges with combining information from different studies of tests called meta-analysis. There might be current tests that exist that are actually imperfect. There's a human resource element which is tests are only as good as the operator. We all experienced that with COVID. Different patient mixes can result in different value. There are the false tests could result with more human resource use. And even the cost of a test is not always easy to estimate, because it's not simply paying for a test, it's paying for all the human resources and other things around the test. So many challenges. This slide just reiterates the same idea that there are government agencies like NICE and CADA, now CDA, that look at test and test performance, but they themselves don't have a strict set of rules for how to look at tests. And so, and there are debates about how the best ways to even do economic evaluation for testing. So many challenges, and I'll pause there again to see if John or Craig, you want to weigh in.
So Don, thanks. What you're presenting is the dilemma that we have with respect to new testing capabilities that are emerging through that genomic or precision health lens. Remind us that there's Alberta has 4,200 different tests. So if you can imagine determining which of those tests should go through a health economic assessment for its value is really a Herculean kind of effort. And so it's really about finding those on the margin that are of value as the health system evolves, as new drugs and new technologies come along, and that quality of adjusted life is an important indicator to include in the determination of the value of that drug and that test combined in terms of its of adding it to the formulary. But it's extremely complex, and I think it when you think about lab medicine as being that 3 to 4%, I think a lot of time policymakers don't want to spend the time, invest the time driving those kinds of things.
Yeah, and just one comment, Craig, just to add to that. Just I've noticed when we worked with various lab companies or also health system decision makers in doing economic evaluation, it's not always an enemy in some particular cases.
Yeah.
Often, sometimes there's a bit of an overvaluing of the benefit that might come from a particular new technology, and it's an unrealistic presentation of the benefits that might be received. And it's good to be aware of those as one is trying to pitch and incorporate that technology. But sometimes, often, people involved in developing tests undervalue the benefit, actually, and that economic evaluation can actually provide a significant demonstration of value beyond the actual efficiency of the particular test and that kind of thing. And so I think having that kind of realistic, it's not always a tight fiscal perspective. Often economic evaluation can significantly provide the value story, a more positive value story in terms of pitching for incorporation of that technology in a health system.
Yeah, absolutely. And I think that's the piece that laboratorians need more support in, is finding those strong stories to support the investments versus looking at it as a cost.
Yeah. But Don, perhaps this is, I think you want to do a quick overview. We had we did some work recently about looking about emerging issues in lab medicine that related to economics in most cases that deserve some policy attention. But over to you.
Excellent. Yeah, and your points are well taken. Governments that use health technology assessment to inform an economic evaluation to inform testing, they have to think of ways to either prioritize and only do evaluation on those things that really truly create some uncertainty, or implement other ways to, because you can't do analyses on every single test that comes along. So yeah, there are, in addition to challenges with economic evaluation, there are also policy challenges, and this is a busy slide, but these challenges often relate to the availability of tests or the equitable access to testing across regions, standardization, how test and test information is shared, and the like. There are a number of issues surrounding laboratory medicine that go beyond just is it a good value or not. It's about how do we implement this in a way that's going to give people fair and good access to testing. There were, and because there are a number of issues, there are also policy responses to this. And one sort of very common thing that we've heard about in recent years is the overuse of testing, or tests that are really ordered. This is often in the community, tests that policymakers feel have little or no use, and yet they're ordered all the time. And there actually have been policy initiatives that have been implemented to address this, including choosing wisely, which a lot of people have probably heard of, which creates recommendations about what sort of testing might be necessary, what tests might not be necessary, and the idea of removing tests from, or testing protocols, or even modifying requisition forms so that some tests that probably shouldn't be ordered are actually ordered more appropriately. Yes, and we at the Institute of Health Economics have also conducted an exercise looking at the literature around what policy issues are there, and also speaking to several laboratory leaders across Canada to talk about what do you see as main issues, policy issues. And this is the kind of thing that we landed on. These are the themes that emerged: the value, financing, stewardship, organization of care, new and disruptive technologies, and equity. I'm just going to quickly go through these issues one by one. Value, I've touched on what is the value of a test, but some of the questions that policymakers have are what's the real value of laboratory service? So again, because we're not looking at the value of, sometimes we're looking at the value of individual tests, but what about laboratory services as a whole? How does that compare with other healthcare services? And are there low-tech solutions that can even promote value further? So I discussed sort of one way to reduce the overutilization of tests to modify requisition forms. And I know of one Canadian jurisdiction that took a test they didn't really want to order that often and put it at the back of the form or the bottom of the form. And they found that if people had to scroll down further or turn a few pages, they actually ordered the test much less. And so by simply reordering where it was on the checkbox, they actually saved a bunch of money because people thought twice about ordering a test just because it wasn't immediately visible to them. Low-tech solution. Financing is another big issue. Again, often tests are seen as a cost center, and we don't look at the larger clinical value. But there are things that we can think about, like what is the role of value-based procurement or value-based healthcare in testing? Are there ways of giving the budgets for testing to physicians or others so that testing can be spent in a better way? One of the problems in healthcare, of course, is the moral hazard associated with technology that a physician can order, but they don't have to pay for themselves. And so if it's free, we just we order it up. We have to think about how will new technology need to be financed, because we have now tests that are increasingly going into people's homes or in communities, and so we can't simply just give money to the laboratory anymore. Potentially, we may have to find other ways of paying for that. And conversely, are there different ways that we can pay for testing that actually can reduce inappropriate testing or increase value from testing? Stewardship is another theme that emerges, and this is about utilization. And so again, the choosing wisely idea, can we realign incentives so that the utilization of testing is more appropriate? Can we use education or standards or something else also to improve the efficiency of laboratory services? So again, these are all policy issues that go outside the actual technology itself. Similarly, can we reorganize how we deliver testing? And I think we all now see blood pressure machines, for example, in pharmacies, completely supported by the pharmacies themselves. So we don't necessarily have to go into a doctor's office, and people also buy their own devices and bring them home, etc. We saw in the era of COVID, people bringing COVID tests home, but we also saw, again, the role of pharmacies. We could extend that to other people within the healthcare system, paramedics, etc., to think about how people shouldn't have to necessarily go to a laboratory. They could have the laboratory coming to them, or be in a different part of the community. Obviously, when we think about economics and testing, we also think about new and disruptive innovation. And this ranges from, I mentioned already, genetics, genomics. We have digital pathology, which requires massive storage of data. We have point of care tests. We have maybe new roles for laboratory medicine. We have I mentioned genetics, pharmacogenomics. There are a number of new and upcoming, obviously, technologic breakthroughs or in process of care that we have to think about that might disrupt the way we deliver laboratory medicine. And then finally, and this also was touched on, who gets testing and how do we ensure fair access and equitable and consistent access? And there are issues related to how we can do that, particularly in Canada, where we have some jurisdictions that we have rural and urban centers, and we want to make sure that people are getting equitable care.
And Don, just one comment, the issues identification we went through in talking to a number of people who work in the field. And we're hoping to plan in the future to actually pick some of those particular issues and actually have a follow-up webinars. So this introductory webinar that we have, we can maybe pick some of those particular issues and have it as a bit of an ongoing series to explore some of these kind of emerging issues, particularly the use of laboratory medicine strategically. I think more importantly as it moves forward. So just pass over to you.
All right, well, and I think we're summing up for this section. Value-based approach, which considers economics and what we're getting and what we're giving up, can optimize the sustainable adoption and implementation of test-based care, and may actually free up resources for other things, particularly when tests have a very high value proposition. So something, again, to be thinking about. So I don't know if you have any, John or Craig, you have any further comments before we get to the end of this?
You know, Don, I think the notion of disruptive technologies in lab medicine, in fact, is going to play a larger and larger role in terms of how lab services are delivered. And in fact, thinking about how lab services are delivered to address things like equity and sustainability is going to be more and more important as we talk about how we sustain our healthcare system. So, you know, the slide on disruptive technology really speaks to a potential shakeup in the lab system. And I love the notion of moving away from bricks and mortar, certainly on the community side. But we're seeing real opportunity in things like digital pathology and point of care in non-traditional spaces to actually change the trajectory of how labs services are provided and reach the populations. And so in certain ways as well, we need to think about how lab gets delivered and what policymaking tools need to change to support that. And so it's, you know, lab itself has a velocity of change, has always had a velocity of change that's different from the rest of the health system in terms of the technologies that it continually brings online. So it's something that I think policy is always chasing to catch up in that space, but we're facing a very disruptive time, I believe.
Point taken. Okay, we have one final section. It's not as long. We're just again want to re-emphasize the idea that economics and economic evaluation can be your friend. I hope we've made the point that it's a bit complex, but not doesn't have insurmountable challenges. It has to deal with the policy challenges that policymakers face in order to be useful, and that there are still there are and will be a number of issues related to laboratory medicine and the economics of laboratory medicine in coming years. But you know, economics ultimately can be used to change the image of lab medicine. So, because it illustrates the great value of what we get when we invest in laboratory services. That could change the way we actually perceive laboratory services. It can also help us understand, because it's intertwined with so many services, can help identify relevant services, streamline diagnostic workflow, but not just diagnostic workflow, but care pathways and care processes, because it's such an integral part of that. And by doing so, can address ultimately larger healthcare system inefficiencies. Remember that, you know, and I said at the beginning, economic evaluations about what you're prepared to give up to get something. We do, of course, think about the health of patients. We do think about the quality of life of patients. That's when we may have other outcomes like productivity and the like. But we also think about patient experiences. And we now have new tests that can reduce the patient's need to go and be referred to different services and reduce the amount of referrals from specialists to general practitioners and the like, and improve their life in that way. It can also improve the care provider experience. You know, we now see in, for example, oncology, where a tumor is tested for all kinds of things up front, and that actually improves the experience of both the patient and the oncologist, who now don't have to spend a lot of time doing additional tests and follow-up and running around, particularly if you have a cancer, and that's not exactly something you want to be doing with your life. So and by doing so, it can actually improve the healthcare, the morale of healthcare staff, which is also an important outcome that any healthcare administrator wants. And I hinted at it before, but you know, more and more testing will also help us understand disease, and that actually then creates opportunities for creates commercial opportunities, creates opportunities for science and discovery, and all the things that spin off from that. And so not only, and testing is one of the few things that does this. I mean, if we pay for, you know, some standard service, like a family physician visit, we don't necessarily learn more about the human condition, but we may learn much more if we invest in testing. And currently, the way that we see this is that there are silos between and within sectors in the healthcare system. We've already mentioned there are silos within laboratory medicine itself, where we have all of these different specialties. And then we have systems, even in Canada still, where laboratory medicine is siloed across, for example, a province. And this can be a challenge for laboratory medicine. We may see significant funding, but the lack of all of the infrastructure needed to support and optimize the benefits and efficiency of the use of healthcare systems as well. For example, in the era of genomic medicine and genetic medicine, we need investments in information infrastructure in order to be able to use those things appropriately. Similarly, digital pathology, we need investments in information technology. So it's not just about funding laboratory services, it's also about funding the infrastructure required to support it. We have seen a movement towards more consolidation and integration of laboratory services and a recognition of this. So the things that we're saying are not revolutionary, I think, and they may be known to a lot of healthcare systems, but it's not always easy to bust the silos. We see, for example, in the province of Alberta, Alberta Precision Laboratories has a more holistic view of the use and delivery of laboratory services within that province. And there may be other ways to think about the governance and financing of laboratory medicine that actually could improve the use of tests. So same test, different healthcare system may have a much different value proposition depending on how the healthcare system is organized and funded.
Yeah, Don, just to comment, I do think that in terms of new funding models, there's a lot more integrated funding models being developed where lab is considered and incorporate in funding a whole care pathway rather than just seeing as a separate cost center, because sometimes the very expensive test is hard sometimes for the lab to promote. But if it's part of something where investment in that early expensive test might actually improve the whole care pathway, if you're bundled as a kind of a horizontal silo along the continuum of care, you can have much greater chance of incorporating funding for that investment along that line, rather than being as a separate kind of cost center silo that people have to access. And I think there's some examples increasingly where you can have bundled payment value-based healthcare approaches, which are opportunities for lab medicine to demonstrate their value, rather than seeing as something where it's associated as a cost center, like cleaning the hallways or something like that, in terms of that kind of thing. But it's seen as a clearly strategic.
No, it's a good point. And like even within the province of Ontario, for example, tests for hematologic cancers are funded using a kind of activity or care-based bundle pathway. And that's a way of driving value in the healthcare system to make sure that testing is appropriate. But it's also it's a different way of thinking about how you finance testing, and which is value-based rather than cost-based. I think that's what I have for slides. And so John and Craig, I can get you to launch into a discussion.
And yeah, certainly over to Craig. The
Sure.
one thing is, I think, had some perspectives as a lab executive dealing with it, where it's either been helpful or harmful in economics. And also, I think you had an interesting example from BC of how on a system-wide basis, there's some interesting development that happened in the area of mental health and being able to identify things. But over to Craig.
Yeah, thanks, John. Thanks, Dan, and really, sorry, Don. Really appreciate the excellent presentation on health economics and the fact that it is a friend of the lab, friend of the health system, actually. And I think you have to. One of the things we're kind of saying here is what is your point of view? Or more simply, what team are you on? You know, lab can be considered as an analogy to a business-to-business commodity, or lab could be viewed as a transformative agent in the health system when leveraged appropriately and when coupled with the full clinical pathway and health economics together. I happen to be on the point of view that lab medicine is indeed a transformative force that improves health and healthcare. It's not about improving the lab in and of itself. It's what comes through the lab and how it impacts the outcomes of Canadians is where I really believe in the power of lab medicine. And while it's an old saying attributed to William Osler, maybe what's old is new again. William Osler once said, as goes your pathology, so goes your medicine. And I think there's no truer word today as we look at the kinds of technologies, the kinds of capabilities that are emerging in lab medicine, and how they have to be coupled with programmatic strategies or health system strategies. Take the move from conventional cervical cancer screening to moving to HPV primary testing. That alone, that storyline alone, doing the testing alone and paying for the testing alone doesn't create the business case justification as a standalone, but build in the implications for society and use health economics for end to end with an objective of eliminating cervical cancer as an objective. And you have a very powerful message where you say, why wouldn't you lean in on the transformative power of lab medicine as a part of that storyline? Alone, it's a hard sell. As part of a program that is endorsed by the World Health Organization, brings value to marginal populations, indigenous populations, and immigrant populations who are not comfortable with some of our health system in how they access it. And it's a very powerful tool. And John mentioned the notion of the work that we've been working, the work that's been going on here in British Columbia, wherein we're looking at the impact of genomic marker identification in terms of individuals' ability to actually effectively use the drugs to treat major depressive disorder. The study and the work done illustrated over 20 years, a $900 million net savings to the health system. Very powerful storyline. Louisa Edwards and Sterling Bryant's remarkable scientists who did the work along with others. And it's a storyline where, we've yet to come to the point where we look at that story and say, where do we sign on? Where do we move this forward? Because there are still policies and perspectives that say, that come back to us and say, well, how much is that test going to cost? And the reality of it is the testing cost on an annual basis might be in the order of $2 to $3 million, but the payback on an annual basis might be around $45 million. And yet we're hung up on the $2 to $3 million. So there are opportunities. And I think health economics is really a powerful tool to highlight and drive the notion of value, the value of lab medicine. And of course, we keep going back to the COVID experience and recognize that in some ways, certainly here in British Columbia, we saw the power of lab testing to help open society, to help the economy move forward at a time of uncertainty. And so the reach is remarkable for lab services. And I will just go one step further and say, when you think about lab medicine as well, you do have to think about it on a system level. So you think about the strategies and the approach in Alberta with Alberta Precision Labs, a single lab strategy that assures cost effectiveness, assures equity, assures innovation, assures wise investment, and use of scarce human resources at a time when it's really important. And you contrast that to, say, the fragmented models that are involved in Ontario and indeed in British Columbia being an equivalent size and scope to Alberta. We have 12 different lab enterprises, all very much with strong autonomous points of view. And the challenge to integration there, I think, costs time, money, and energy better spent on healthcare. So I think there's a whole range of things that should be thought about when we when we consider the future of lab medicine. And I think Don's done an excellent job of highlighting how we should be using health economics to really drive home that message.
Okay, no,
John.
thanks so much, Craig, because I do think our main objective was providing an introduction and a presentation of health economics, how it's not, health economists are not accountants. There's lots of those of finance people who can map over there and look at it for a bit of a more comprehensive system look and a time horizon, and also can assist with business cases either being done by laboratory medicine within health system organizations or innovative companies wanting to present their particular kind of case with some rigor and some scrutiny that can kind of pass muster. Because I think there's realistically, as we tried to highlight, there are issues in laboratory medicine where there are some imperfections in the tests always, but them needs to manage that to really maximize the particular kind of value moving forward. And I think the other thing that's highlighted is Don tried to highlight is often lab is thinking as a test that might inform a physician to make a particular kind of prognosis or a diagnostic certainty around an individualized medicine. And increasingly, and Craig, you highlighted, it can be used as a system planning tool in exploring populations, and also there's new modes of delivery as we move out of bricks and mortar into community-based settings where we really have to capture that. And I do think there was an opportunity with COVID, frankly, where the public got used to testing. It was a wonderful learning exercise where people started to understand lab tests and regularly got involved. And I think there's some lessons that could be learned that could translate to other chronic disease and illness. But just on the next slide, Don, I did want to note, Craig and are both involved in the Univance program, and Abbott, who helped support this initiative that we're doing right here. It's been a wonderful kind of partnership, but the Univance program, I encourage you to go and look at it. Univance of Healthcare Excellence, you can type into your web browser. And the August 1st, there is the applications are now open, so go and look at it. And the deadline is November 2024. And timely congratulations to Craig, actually in British Columbia, which was one of the award winners this year for some really unique work in HIV testing. If you want to just explain that program, Craig, just specifically what that was.
Yeah, I love it. So the Univance program is intended to identify innovative programs that blend a clinical program with a lab back end, and together they submit that application. By the way, I had no influence on the outcome of that particular awarding. It was a Get Checked Online program for sexually transmitted diseases and bloodborne infections. And it was Get Checked Online was an anonymous opportunity for people to take their health into their own hands. It was a collaboration between public health, BC CDC, and collaboration with the public labs in the province to actually enable anonymous testing and to enable those folks to take control of their lives in a very active and proactive way. And it received very positive reviews through this program. So thanks, John, for mentioning it.
Yeah. And so encourage people to share that information. We will be providing we're just closing now. We'll be providing the PowerPoint slides, and we'll be posting this webinar online, sharing it with you all, and we'll be posting it through social media, but also through on our website, so that people you feel might benefit from this webinar. And stay tuned. We'll make sure to keep in touch with what we hope to be some deeper dive on some of the issues that we've been able to identify today. But thanks very much again to Abbott, who helped support this, and to my colleagues, Don Husereau and Craig Ivany. And we are on time, and I wish you all a marvelous rest of the day this Thursday. So thank you very much for joining us.